Good afternoon, colleagues. I'm Dr. Nasike from Turkana. I work as the Supply Chain Strengthening Advisor for Save the Children. I'm doing that because Dr. Tabitha has requested to know why we are saving the children. Save the Children is an international organization that is in around 120 countries, UK-based, and its main core values are to make children survive, to learn, and to protect them. So we deal with children in terms of supporting their health, in health and nutrition, WASH, and also in education programs. So my study is integrating treatment of uncomplicated, severe, and moderate acute malnutrition into ICCM. So next. So I'll just start with telling you what is integrated community acute malnutrition. And ICCM is a strategy that most ASAL areas are actually employing to treat, to support the community health volunteers, to train them, to treat, to diagnose children under 5 for the uncomplicated childhood illnesses of malaria, pneumonia, and diarrhea, and also acute malnutrition and neonatal sepsis. It actually goes to the level 1, which is the community level of the community health strategy, and it needs linkages with the health facility that is linking to that health community unit in terms of mentorship and support of the healthcare, of the CHVs, and also provision of the commodities. It's an evolving strategy which in Turkana was started in 2014 and in Isiolo at the time of research in 2018. I was discussing with a colleague from B. Brown, and he was asking me, why are you promoting the CHVs to take over the work of the pharmacists? So my colleague, you can just listen and then you'll understand why. So in ASAL areas where distances between health facilities, and which is mostly level 2 and 3, can go to as long as 20 kilometers. So you can imagine a mother with a sick child has to walk all that way just to go and access health services. And according to the SDGs, by 2030, WHO is recommending that we have the infant mortality rate of the under 5s at 25 deaths per 1,000 live births. But currently in Kenya, according to KDHS 2022, we are still at 41 per 100 live births. And for infant mortality, we are still at 32. And also the cases that can be pointed to management, due to management of diarrhea, only 31% of cases are managed at the community level. So you can see in efforts to bridge that gap, that's why we have to employ such mechanisms at the ASAL communities in order to reduce the mortality and morbidity of the children under 5s. Other than that, the aim of the study was now to see how CHV management of the uncomplicated wasting or management of acute malnutrition can be incorporated as part of the ICCM, which is already ongoing for malaria, pneumonia, and diarrhea. So there was 4 typologies where in the beginning, we just capacity building the CHVs to advise on the feeding of the sick children, to advise the caregivers. And then the second one was the advise and link to where they can get help, and also link them to how they can use social behavior change methods just to improve their health outcomes. And the last one is where we wanted to see if we allow the CHVs to do the management at community level of moderate acute malnutrition, what will really be the outcome, as opposed to waiting for them to take the children and enroll them in the IMAM program. So the research objectives, the primary objective was to determine the effect of integrating treatment of severe acute malnutrition and moderate acute malnutrition of 6 to 59 months into ICCM, but in the process also to see how the CHV's performance will be, because this is an extra workload, to describe also the CHV's experience as we had to use simplified tools, and also to assess if there are any challenges affecting their management at community level, and the cost effectiveness of managing malnutrition at the community level. So the design and approach that we used is we had two control and intervention arm, which are parallel groups. We used randomized control trials with a mixed method approach, both quant and qual. And the study population was 6 to 59 months. So in that case, the control arm, the CHVs will just screen, and if they get a case of acute malnutrition, they would refer. And in the intervention arm, the CHVs were trained to screen, and if they get an uncomplicated case, then they enroll them and start treating. Next. Yeah, so that was the pre-randomized case trial phase. So we had the phase was done in 2 phases, January to September, and then in 2018 and in 2019. Next. In the design phase, we realized that we will have to simplify some of the equipment and tools that are used because of the level of comprehension of most CHVs. Most of them are illiterate. That is the standard MOAC tape that is used to take the mid-upper arm circumference for malnourished children, as you can see, so that the CHV can just know if the child is either moderately acute malnourished, if they are the pink, or if they are the yellow, and if it's severe, then it's the pink and the dark brown. And then for severe acute malnutrition, it be at the red. Next. So that was the treatment flow. So the trained CHV will will assess the child for danger signs. And some of the danger signs associated with the acute malnutrition, other than wasting, is edema on one or both feet. So in such a case, the CHV would refer immediately. If not, then they will take their MOAC, the mid-upper arm circumference, and as I have explained, based on the color code that the mid-upper arm circumference will show, then they will either enroll them on moderate acute malnutrition register or the severe acute malnutrition register. And if the color code is bright red, that means that child needs to be managed as an inpatient at the stabilization center. So they will have to refer immediately. For a child that is moderately acute, he will have to weigh, and then there's a dosage mat that I'll show you below, where a child gets one pack of RUSF, ready-to-use supplementary feed sachet, and if it's some, after the appetite test and they've passed, they will be given the ready-to-use therapeutic food based on their weight. Next. Yeah, so that is the simplified tool, that is the weighing, the Salter scale that the CHV uses to weigh the child. So for a severe acute malnutrition, malnourished child, based on where the weight band will lie, that child is supposed to get either 2 sachets per day or 3 sachets or 4, depending on their weight. And that is the dosing mat. So it's a mat that is put on the floor for their ease of comprehension, and then they explain to the caregiver how many they'll use. So for the severe acute malnutrition, you give 7 days, and for moderate acute malnutrition, you give for 14 days. Those are the simplified registers. So as you can see, they are color-coded, and they are using pictorials just to show the outcome. So if it's a boy or a girl, as you can see, the genders are there. The age of the child, if they are crawling, if they are walking, if they are running. So the CHV can mark based on the on what they see. And then also at the bottom there, you can see the outcomes. So if a child is referred, if a child is need to be taken to the hospital, it's there. If a child dies, it's there, so they know how to mark. Then for the referral criteria, so the CHV can refer during assessments or during treatment. So during assessment, through assessing the danger signs, as I had reiterated, and they find, even if it's just one, they'll refer, or if their MWAC is below 9 centimeter, or their weight is below 4 kgs. And in the course of the treatment, some children deteriorate. So in case that's the case, then in the course of the treatment, if development of danger signs, or the regression of the MWAC measurement, or there is stagnation in MWAC, then that is also qualifies for referral. Yes, so those are some of the results. Maybe take me to the next slide. The one. Yeah, so I'll just summarize that from the treatment, where in Turkana we had 272 children, and in Isiolo 127. Before the study, you could see that the defaulter rate was higher than after in both counties, and also the treatment outcomes improved after the study than before. You can see the yellow bar. So in summary, the cure rate increased by about 17% in Turkana and 30% in Isiolo. The defaulters reduced by 19%. Also, the average length of stay in the program reduced from 26 days to 20. The coverage for the GAM rates, or the global acute malnutrition rates, were actually similar in the same. We picked an area where the GAM rates are similar. And for Turkana, more than 80% of CHV correctly performed their actions, as we were also assessing the performance. So other than their other job that we've added the management of acute malnutrition, they still correctly performed, while in Isiolo more than 70%. I'm almost done. So some of the key successes, we managed to disseminate these findings at county and national levels, and it actually informed advocacy steps on the management of SAM and MAM at community level, especially in ASAL areas. And it has informed a policy that is actually under the Ministry of Health, in the Ministry of Health, in the Division of Community Health and Family Health. There is also scale up from the 5 units that we were doing in Turkana to 20. I think that's the last. Next. Yeah, so those are some of the enablers and the barriers. Some of the enablers is that the counties got interested because these are counties that are mostly drought-stricken, and sometimes they face a lot of problems in managing the populations that succumb to malnutrition. Then there was county bills that has been passed in Turkana, for example, to provide CHVs with a stipend. Also, the pneumonia policy has been adopted into integrated acute malnutrition, and I think the HPTU was involved in the whole process. And supply chain for nutrition commodities also has been integrated to the MOH mainstreaming. And somebody was saying, well, pharmacists are managing medicines. I tend to disagree. Most of the commodities that are used, whether it's reagents, whether it's nutrition commodities or whatever, anything that has therapeutic implication needs to be under the umbrella of the pharmacist. And these are some of the things that are showing that we can be dynamic and we can find our space, even at the PHC level. Then some of those barriers, as you can see there, and some of the next steps, disseminating, as I've done to PSK, through the global TW and the rest. I think I'll stop.